Welcome to a new edition of LINNCPARIS. This time I have the pleasure to interview Professor Vincent Costalat from Montpellier, the first author, lead researcher of the LASTE trial or LASTE trial. I am Daniel Vela Duarte. I'm a neurointerventionist in West Palm Beach, Florida, the US. And I have the pleasure of having him here to ask a couple of questions about the trial. So welcome, Professor Costalat. Congratulations again on an amazing trial, well conducted, amazing results. Can you walk us through the main results of the trial to just give an introduction to our community?
Yes, we have presented the complete results in Slides 2023 last October, and they were extremely surprising. I mean, we were completely surprised by the results. Main results of the trial is that people that are harboring an aspect score 0 to 5 in the first 7 hours are still benefiting from an early reperfusion of a thrombectomy. And the question is about futility of those reperfusion. And the answer is there is no futility, because even in the group of aspect score 0 to 2, you still have a huge benefit into having a reperfusion at the acute phase. We have observed a decrease in terms of mortality of 20% compared to the control group, and an MRS score at 6 months that is up to 18%, meaning that one patient out of 5 that's been treated will come back home despite this very large score.
Definitely. The inclusion criteria of the trial, if I remember correctly, is 6.5 or almost 7 hours from symptoms onset
Yes.
to treatment or puncture. Where does that window of opportunity come from?
So it comes from the fear that maybe after most of the brain would have been dead. So it was just a bet already to include the 0, 1, 2, whereas all the trial just were trying to focus their evaluation on 3, 4, and 5. So it was a lot to take 0, 1, 2. Everybody was thinking, oh, LASTE, it will be difficult to make. But if it's positive, at least we will have to set the threshold. So people were thinking, and we were thinking, maybe at one point we will define the threshold. Maybe 2 would have been the threshold. And then we will have understood the futility below 2, 2, 0, 1, and then it was useful 3 to 5. So we were already taking risk, to include 0, 1, and 2. So the wise thing for us was at least to do this in the early time window.
One of the unique features of this trial is definitely the fact that it has secondary outcomes at 180 days, or basically 6 months, and also the as you mentioned, 0 to 2 aspects. There is certain hesitance of the community to apply these results, especially in community hospitals, outside of academics.
Yeah.
What's your perception of how the community will receive or already receive these results?
I think LASTE was the missing piece of the puzzle, but the puzzle was already built by the previous trial that was showing to us that between 3 to 5 and up to 15 hours, there was a very important therapeutic effect on thrombectomy. But all of this was based on the understanding that there was a dead brain, defined by the imaging, defined by the core, and a penumbra that was a survival brain that we may save by the reperfusion. And what we understood with the large core trial, and especially with LASTE, is that this unique concept of macro penumbra and core is false, meaning that inside the core you have tissue that's still alive. You have islets of neurons surviving, unless you cannot explain the last results. Inside the core, there is an heterogeneity of the death, okay? There is surviving tissue. What is very interesting is to see that on animal studies, for the last 10 to 15 years, scientific like Del Zoppo and other teams already demonstrated that inside what we were calling the core, the necrotic core, there was islets of neurons. So the big problem we had in terms of concept is that we have understood the brain imaging as being the definition of death, of cellular death. It's not. What we see on CT in the first 6 hours, what we see in MR, it's acute suffering of the brain into the core. And of course there is cells that will die into this core, but there is cells, if you do an early reperfusion, that will recover. And I give you a very smart, very simple example that I'm sure you have already experienced. Did you already have someone with a large core that you have treated by mistake and being surprised by the outcome of this patient? If you look the CT and the MR, there is a scars, and people will say, oh, this is the sequela of the infarct.
Right.
But inside this sequela, there is still some tissue. And there is not only glial cells, there's also surviving neurons. And those surviving neurons, they play a role, they make connection, and they help partially the patient to keep a function. That's why you can help patient, even if you see dark images on the CT or the bright imaging on the MR, by making an early reperfusion in the first 7 hours.
So to this very interesting understanding and a concept of how to understand penumbra these days, based on what you have explained and based on the study, I have 2 points to ask you. The median time from onset of symptoms to intervention is about 5 hours, like 305 minutes or so. And also, the patients that were older than 80 years old were not enrolled in the study if they had aspects less than 4.
Yes.
And so are these patients, are these individuals fast progressors technically?
Yes, I think they are fast progressors because we took patients that are with a very large core in the very early time window. So this may represent up to 10 to 15% of the presentation at the moment in the population. And of course, the results of the last trial are true in the first 7 hours. So I do not know at all if we can apply these results at 15 hours, 16 hours, 10 hours for the aspects 0, 1, 2 patients.
That remains uncertain at this time.
That remains completely uncertain. And for the question of the age, the same. We wanted to exclude those old patients, the old patient, because it was already too much also to take patient 0, 1, 2. So we have to limit the conclusion of our study to 80 years old as well.
So by looking at the subgroup analysis, the treatment effect is basically preserved across several groups, volume, age. But I did not see, and I wanted to ask you, I did not see whether there was an analysis based on dominance, based on whether the right hemisphere was involved or the left hemisphere was involved.
No, there is no at the moment, but the results we have on previous trial on craniectomy or things like that most of the time do not show any difference, but in the sub-analysis we will have those results being present.
Okay, and I believe one of the last questions I had for you was how is the community going to incorporate or what does it have to happen for us to get this on the guidelines?
I think there is a very simple message. At least in the first 7 hours, brain imaging assessment should not be a reason to exclude a patient from treatment. If you don't treat someone in the first 7 hours with a large vessel occlusion, do not do it just because of the imaging, because you know that the treatment effect is still very strong. You have to exclude him because he's 91 years old and he has a previous cancer or something like that. You need to exclude him for this reason. But do not exclude a 60 years old male aspect 1 at 4 hours. That's a big mistake.
Okay.
So this will change, I'm sure. LASTE combined with all the other trials that were positive 3 to 5 will change the guideline very soon.
Are you planning on following these patients more than 180 days and do another type of analysis if they still are doing okay?
Yes, we are planning to make a long-term follow-up, at least 1 year follow-up on those patients. It will be, yes, a long-term evaluation, but it will not belong to the level 1A of evidence we were able to expose with the initial trial. It will be an ancillary study.
Excellent. Well, to wrap up this nice conversation with you, what's your best advice for our young community of neurointerventionalists in order to incorporate these patients in our daily practice here?
So I think LASTE is a game changer because it shows us that there is something to do on the core. because we thought that this was completely dead, and it's not. So it's opening a big door, a door to pharmacology, because after reopening, you know, this tissue that is revascularized, that was dark in CT, a part will survive. So how can we bring therapeutics, medication to help more tissue to survive to the stroke situation? So I think it's a big door for research, for pharmacology, and we need the young generation to develop this field.
Thank you very much again.
Thank you.